Hello and welcome back to A Modern Pharmacist with me, Lee Smith. Now, 1 in 5 people have this inherited cardiovascular risk and they probably do not know that they have it. And to be fair, not many healthcare professionals know anything about it anyway. So what is it that I'm talking about? It is lipoprotein little a. And I'll even hold my hands up that even, I think it was about 2.5 years ago, I didn't have a clue about this thing at all. And the fact that I didn't know about it and now having looked into it so much and advocating for it on a level that I never thought I would, it just baffles me how we are not using it within general practice, within cardiovascular medicine, because it is a highly useful biomarker. And the reason I've looked into cardiovascular disease more than anything else is because it is still the biggest killer globally. And the tools that we're using to treat it and prevent it are so primitive, despite having a wealth of evidence and information in front of us. So I also wanted to discuss LPA because it's been brought up in the media recently. There's been a celebrity who was diagnosed with a genetic heart condition. And I was like, well, what is this? And it was just a high level of lipoprotein little a, when a lot of people, like I said, 20% of the population will have a high level of it. And myself included, I have an extremely high level. So mine come back, and this will mean something later on in the episode. Mine come back at greater than 240, which beyond that point, it wasn't able to be calibrated through the lab that I had used. So I am in a very small minority, and it just adds to all the other things that are going on for my wonderful risk assessment when it comes to metabolic health. So what is lipoprotein little a, and where does it fit into cardiovascular medicine, heart disease? I feel like the best way to explain it is going back to LDL cholesterol, which is low density lipoprotein cholesterol. If you can also hear a meow, I got a kitten last week. He was in here. I actually normally do these podcasts on a first take with no editing. But I started recording, I got about 15 minutes in. He basically started knocking the camera over, knocking the timer off, so I didn't have a clue where I was. And I put him outside the room and he is crying to get back in. So if you do hear that, that is him. We're not obviously being mean to him. But if we go back to explaining LDL cholesterol, like I said, low density lipoprotein, which is known as bad cholesterol to a lot of people, even though there is no such thing. If you think of this as a spherical shape, and the reason I'm saying this is that it allows you to visualize why this other particle that I'm discussing is so atherogenic. Why does it cause so much of an issue when it comes to heart disease? And another point I need to make is that if you watch my podcasts or listen to them, there's no debate from my side that cholesterol has a causal relationship with atherosclerosis when it comes to heart disease. So that's not what we're discussing here, whether maybe having high levels of ApoB and cholesterol are going to lead to heart disease. I've already cleared in my mind and a lot of other people's mind who I respect in the field that this is unequivocally backed. So if you have an LDL cholesterol particle, which is a spherical sphere, you then have a little label attached to it, which is ApoB100. And this is essentially its signaling molecule to the rest of the body. It tells the liver, it'll tell other cells, and it interacts with the LDL receptor. I'm not going to discuss ApoB in any more detail than that, apart from that is your general low density lipoprotein particle, which has the ability to cause heart disease, and that is what we focus on greatly. Now, when you take lipoprotein little a as a particle, that particle I've just discussed with a little apoprotein little a attached to it. So it's bound to it, or bound to it, should I say, through a covalent bond. And then if you want to think about it, it is like snow chains around the rest of the particle. And why that becomes an issue is that it is able to pick up a lot of phospholipids, which when they are then oxidized and they're put into the artery wall, they can wreak havoc when it comes to heart disease. And there is another reason as to why this particle is so problematic is that it mimics something called plasminogen. And I will again come onto this in greater detail in a minute. But when you mimic plasminogen and you compete with it, you are then preventing the breakdown of clots. So it then puts your body into something called a prothrombotic environment, meaning that not only does it have the ability to cause a plaque, it will then have an inability to break that clot and the plaque down, if I can speak correctly. So that is why it is quite bad, and that is from a structural point of view where it is. Now, when it comes to testing, I think it's good to touch upon this now. The NHS doesn't really offer this. I mean, you will probably see maybe 10 patients a year through a specialist lipid clinic who've had access to it. But in terms of having access to request it, normally we don't. And what we normally have is the generic lipid panel, which is what always gets me. So when we're looking at the biggest killer on the planet, what do we do in terms of assessing your heart disease risk? We've got blood pressure, which is a very good marker. Always do that. We may put you on an echocardiogram and tie you up, wire you up to an ECG, and that is only in very, very rare circumstances, and that will give you some sort of structural insight into the heart along with its electrical conductivity. And then we look at the vessel structure, and we do that using cholesterol profiles, which are your total cholesterol, LDL cholesterol, non-HDL cholesterol, HDL cholesterol, and triglycerides, which they all give insight and they are good. But given the fact that we've got greater tools to use, they do not offer as much insight into cardiovascular disease prevention. So that is what you would normally get. So you've got to go private for this, and that's what I've done. Obviously, I've got a company where I do that through health coaching, but this is not a plug for that. It's just saying that I found it very hard and difficult to get that tested, and I had to go and set up a company to do that. But you can go through these companies now. It's relatively inexpensive to do so, and I would advise everyone to do it because it is a genetically determined marker. So over 90% of results are genetically determined, and there is basically nothing you can do about it, which is a good and bad thing depending on your results. So from the age of 2, you fully express the gene, and by the age of 5, you will have the levels that would normally stay at that consistent level for the rest of your life. So in terms of investment and bang for your buck, when you do an LPA test, you only need to do it once and you will get the results that you need, and you can address other factors based on that result. If you've had a test result, then I'm going to do the results now in nanomoles per litre, just because that's a better use. It gives us more of a particle number, which is always a good thing. If you know how much there is of something in particles, it gives you a greater idea of what is the likelihood of it causing a plaque, because it gives you the idea of seeing how many particles could collide and make this structure. And I think that's probably the best way I can put it without going too far into that. I think that's more to do with ApoB, and I can do that in another episode. But in terms of your levels, so anything less than 75 nanomoles per litre is what we would class as low risk. So if you've got that value, really good. And there's basically a low impact from an LPA perspective with regards to your heart disease or future risk. Now you have a value of 75 to 125, you are classed as medium risk, and then greater than 125, you are classed as high risk. Now, as with all things in medicine, it's not a case of if you get to 125, but you were on 124, the world completely changes and you've gone from medium risk to this high risk category, and that is it. You've got full-blown heart disease because you've only went up by 1 point. It's not that. You are on an ascending curve. So the lower down the curve you are, then you are going to have a greater risk reduction. And it's not like you've cleared the finish line if you are going the other way. So you get it below 75 and you were on 77. It doesn't mean that you are miles away from where you were before. And I just want to make that clear, because a lot of people think you cross this golden imaginary finish line and then that's it, you are risk-free for life. That is not the case. But that is what happens when you come to testing. You have to do it privately, and they are the results that you should be looking out for. So I touched upon it before in terms of why lipoprotein little a is more atherogenic, why it's more problematic than a classic ApoB particle, LDL cholesterol particle. And it's because essentially it's got these snow chains, which when you actually look into it, they're called kringles, and they have different formation. They have different isoform lengths, which some of them can be really long, some can be really short, which is why when it was first discovered back in the 60s, I think it was 63 from the top of my head, there was a lot of, it was underwhelming in terms of the outcomes from studies, because people were unable to identify the amount of LPA particles because of the different sizes and the heterogeneity within the particles that are made. So that is why it was never really brought into the line of basically researchers. I would say probably until the 80s, 90s, and then it started picking up quite a lot. And definitely over the last 15 years, it's made its way into guidelines. It is actually within the European guidelines. It's within Canadian guidelines. I actually don't think it's in the American, but I'm not too sure. But it's in there. So they are advising everyone to test at least once. But again, with guidelines, you're usually 10 years behind. So it may be the latter end of the 2030s, which sounds absolutely ridiculous now to think about it, when we might start doing LPA testing. But they are very complex in the structure. And when it comes to why they cause havoc, I did touch upon before, they have these ability to clog up and clamp a lot of these phospholipids. And when they oxidize, they can go into the arterial wall and they can cause havoc in them ways. But the one thing I didn't touch upon properly was this plasminogen. So years ago, if you actually look, I believe it's chromosome 6, we have a gene that codes for plasminogen. Plasminogen is it's a proenzyme, I believe that's the right term I would use, but proenzyme in terms of if you have a clot, plasminogen is released and then it is activated by another enzyme, which then converts it into an active form of plasmin, which then breaks down a clot. And that is obviously beneficial because you don't want a clot to be there for too long, because you need it to stop blood loss. But then if you keep it there too long, then you stop blood flow to the other tissues and cells behind that. So if anyone's ever had a deep vein thrombosis, you will usually have plasminogen will have been released trying to dissolve the clot, and then we can measure something from that called D-dimer. But essentially what happened was years ago was on gene 6, there was this plasminogen gene, and then that is exactly where we find the LPA gene. And through the crazy world of genetics, it was duplicated, and that is where LPA was formed. However, it had a very similar structure, but didn't have the ability to dissolve clots. It just looked the same. And what happens in medicine is if things look the same, they will compete for the same pathways, the same receptors, but they won't have an action at that point. So when lipoprotein little a is circulating in the blood, it will then bind to a plasminogen receptor and it stops the plasminogen from being activated itself. But the lipoprotein A is not going to do anything. So that is why it creates this thrombotic environment, because it is reducing the body's ability to break down clots. And that's important because in heart disease, there's the idea that we're making this plaque, which can be prothrombotic in its own right. And then you've added this extra complication in the fact that the body is reducing its ability to break down clots. It is then obviously creating this environment for heart disease as we know it. But years ago, if you actually think about the benefits of having this gene, would be if you have high levels of LPA, a lot of people tens of thousands of years ago would most likely have died due to trauma, hemorrhagic shock. So if you've got something that blocks the loss of blood, then it's probably going to be pro-life. But obviously now in the modern era, we don't really have any battles where we're going to have excessive blood loss. So it becomes an obsolete gene. And that's what happens with a lot of things in health and medicine, is that years ago, certain things were in place to protect us, but now because we've surpassed ceilings of where the average human would have lived to many years ago, they then become a problem. So in its own right, it's not a problem, but because we've surpassed normal ages, they are then becoming issues later down the line, which is what you would expect. So now that hopefully you've understood that lipoprotein little a is its own particle, it is not the nicest of particles to have. Once you have the level from the age of 2 or 5, that is basically what you're going to have for life. So now you've worked out that it's not the best thing to have in your blood in the first place. Once you've had your level tested from the age of 5, they can't really change. What is the point in knowing it? And that is a question I get asked a lot. And it's a case of, would you like to know where else you can improve your life? I think that's the best way you can do it. So if you have a standard lipid panel, so let's say you go to your GP and they do a cholesterol profile now, and it'll say low density lipoprotein, low density cholesterol, it will say 2.5. So you may go, okay, well, that's less than 3 millimoles per litre. There's no real evidence from the GP to say to start any medication. I'm only 35. Let's leave it at that. There's probably a low risk of a heart attack or stroke within the next 10, 20 years, which I would agree with, providing that everything else in terms of smoking and blood pressure and all these other things are controlled. But then if you get a lipoprotein little a tested, of that 2.5 of your LDL cholesterol, you could have a really high lipoprotein A content. So you could still be at a really high risk despite it looking quite normal on a normal panel. So that's one of the nuances of these extensive biomarkers of LP little a and ApoB, is that they allow you to go into greater depth, and where the normal cutoffs would have been left alone, if someone's got a high LPA, then there's a need to intervene there because of the cholesterol they've got traveling around their blood. The majority of it is within this nasty, nefarious particle. So let's try and curb and reduce the potential that this will have in producing heart disease. And I want to go into actually what is high levels of lipoprotein little a associated with. The actual leading complication is aortic valve stenosis. So if you think of the heart, your aorta is the artery that takes the blood away from your heart to the rest of your body. It is the thickest of that. And there is a valve just before that, which obviously stops the backflow of blood back into the heart when it pumps out from the left ventricle. And in patients who have high LPA, this valve can become calcified. It basically has bone formations on it. And the LPA levels have actually been hypothesized to initiate this calcification and the formation of bone there. And what happens is if you've got aortic valve stenosis, you then have a lack of pressure in terms of blood flow out of the heart, and most likely you will need a valve replacement. But in terms of if you were young and you knew that you had high LPA levels, like for me now, I've got really high levels. What does that mean in terms of my risk with aortic valve stenosis? It means that it's pretty high. Ideally, I would like to go for an echocardiogram within the next 5 years to see what is happening with the valves of my heart and try and catch it early before I become symptomatic and it affects the quality of my life. And I think that's the big thing, is that sometimes you can't stop the inevitable, but you can obviously make it an easier process. And if I could find out that my valves were degrading at a quicker rate and I get them sorted before I have quality of life impacts in terms of exercise tolerance, then that is a better outcome for me. So that is the number one complication. Underneath that, the risk of having a heart attack or ischemic stroke, which is a stroke due to blood blockage, not due to a bleed on the brain, they're pretty much neck and neck. And that's to be expected because of the process that I've just said before, in terms of once they go into the arterial wall, they then grab all these extra oxidative phospholipids, which have a high tendency to cause even more inflammation. And that's the issue. A lot of people are saying, oh, well, it's not the cholesterol, it's the inflammation that causes it, which to an extent is true. But without the cholesterol being within the artery wall in the first place, there would be no need for an inflammatory response from your macrophages. So this LPA is literally bringing these things in to then instigate this massive inflammatory cascade, which is what then reduces blood flow to the brain or to the heart, which leads to a heart attack or a stroke. After that, you then have chronic kidney disease, which is we're reducing in terms of rate of incidence, but it's still high enough to warrant. And then heart failure is also there, but whether that's due to the fact of the formation of plaques and lack of blood flow and meeting the demands of the body, all them things. So I just also point out that they are that is the hierarchy in terms of complications due to lipoprotein little a. And going back onto why should you know it, or why I advise everyone to check it. Don't get me wrong, it's not nice seeing a bad result when you really can't do too much in the interim. But I feel like if I didn't know that and I went about my life normally and I'm leading a high risk in other areas that I can control, and that brings me on to modifiable versus non-modifiable risk factors. So for example, age and gender. Well, I would say gender. Let's leave gender out of that for the time being. But age is a non-modifiable risk factor. I can't tell my body to reduce its chronological age. That is impossible. I would say gender is fixed, but it's 2026 and there's a lot of people who are becoming inanimate objects. I mean, you can become a table now. That's apparently fine. So I will leave gender aside. But things that you can modify are your blood pressure to an extent. You can have a good diet, you can have good exercise, good sleep. So they're all the things that you can modify, which can then improve certain other biomarkers. So for example, blood pressure has a high risk of stroke, or high blood pressure has a high risk of strokes and heart attacks. So if I can modify my blood pressure, it then offsets my overall risk. And I think the good way to look at heart disease in general, and you could probably apply this to most things in health, but heart disease is the one I'm going to use here, is if you have a score, which is a pie chart, think of a pie, and you think, okay, well, that is the chance of me having a heart attack is 80. Well, 20% of that is due to my lipoprotein little a level. Okay, well, there's nothing we can do about that at the time being, so take that away. 30% of that is due to blood pressure. Well, actually, I can control that, so let's get that sorted. The next one is due to obesity because of the adipokines and all the other things that are poorly associated through obesity outcomes. Then let's control our weight. Well, what about VO2 max? That's got a really good thing. Well, actually, let's improve our exercise tolerance. What about our salt? I'm not going too far into this, but you can see what I'm saying here is that you can then reduce the overall risk of you having heart disease and strokes by managing everything else, which is what I would say when it comes to lipoprotein little a is I'm trying to think of a good analogy for anyone. I think if you have heart disease as the edge of a cliff and you are driving a car, and let's say you are 10 miles away from the edge of that cliff, which is probably about right now, 32 next month. So 10 miles away from the edge of the cliff. If you are in a car, you obviously want to slow down your speed as much as possible so that you don't get to the edge of that cliff. And there are things that you can do to help slow yourself down. So for example, you could have really good brakes. You could take your foot off the accelerator. You could have really good tires, really good downforce. You could have a lot of things in your corner when it comes to reducing your risk or reducing your speed. So lipoprotein little a is essentially putting your foot on the accelerator. So you are ramping up that speed higher than the average car going towards the edge of that cliff. So knowing that you are going to the edge of that cliff, are there other things that you can do to reduce that speed? And I think that's the best way you can do it. I preferably, and have done, and would always advise for you to look at your risk so that you're not living blind and you have full autonomy over what you are doing and just being well informed about what you're doing with your health. But yeah, that's more of a mindset approach to knowing your level, and also to offset it through things that you can modify. But there are treatments on the horizon, and there are treatments that have been tried. So statins have been tried with regards to lowering it. Ironically, they actually led to an increase in some studies, and that's because apolipoprotein A is made within the liver. It is bound to LDL cholesterol particles in the liver. So statins work by stopping the production of cholesterol to an extent, but its main mechanism is that it improves or increases the amount of cholesterol particles being taken from the blood. So if you're taking them from the blood and putting them in the place where you make the protein, there's a good chance for them to merge, which is the hypothesis as to why statins temporarily increase or slightly increase lipoprotein little a. There have been treatments such as PCSK9 inhibitors, which have had about a 25-30% reduction. But when you actually look at the evidence in terms of its outcomes long term with heart disease, it doesn't move the needle enough to warrant being on these types of medications. And also try and get one of them medications outside of its normal licensed indications. So for me, for example, I've got no chance unless I find a private prescriber or self-prescribe, which is frowned upon in the UK, and do it that way. So these are all things that I will be thinking of. But there are some medications on the horizon called antisense oligonucleotides. And essentially they have got really good efficacy when it comes to lowering lipoprotein(a). They've shown reductions up to 98%. I believe the range is 80 to 98%, which is insane. And if they get approved, they are in phase 3. I think the company's Ionis, I think they were one of them. Then that would be a form of therapy that I would be considering, because my family history for heart disease is so high. I still want to test my dad with his level of LPA, because if he has a high level, then there's a good chance I've inherited it from his side. And I will want to try and do a lot of things to offset my risk, because there's things that I've done better than my dad. For example, with the body fat, exercise to an extent. I mean, he does more basal activity than me because he works outside. But one thing that he doesn't have that I do is diabetes, which again puts me in a higher risk category. So I think that's a positive from the treatment side of things. But the hardest thing when it comes to discussing these things is that not many people are going to be well versed in these biomarkers. So you will be putting your head up against a brick wall. So because I try to go through the NHS, because I know these treatments are expensive and I would need to go through specialist clinics to get them prescribed unless I do it privately, then I had to go through the NHS. And when I had a few consultations with the doctors and advanced nurses, obviously they didn't know too much about it, which is fair enough because it is a specialist area. But I just feel as though it is in guidelines, but we should be actively promoting the testing of these things, because it will change the face of cardiovascular disease. It is the single biggest inheritable trait that you can have that links you to heart disease. So why are we not testing it on a mass basis? Why aren't we doing it as part of a pediatric screen? So once they get to 5, just do it as a genetic blood test, and then we've got another data point then for them to say, well, actually, over the next 30, 40 years, their levels are really low. So there's a good chance they probably won't have heart disease unless they do something really ridiculous, where it is go into an obesogenic state or they start smoking 50 a day. Then we could probably, with a lot of confidence, say that they're not going to have too many complications with this. There's a lot of things that I wanted to discuss with regard to this, but because I went down a lot of rabbit holes with it, but I just wanted to get it out there as the first episode relating to this on this podcast series, that it is something that you should all be looking into. It is something I've done, and I advise any patients I come into contact with to get it tested, as it gives you a greater insight. And the quicker we can get your levels down through treatments or offset your risk through other things by lowering your other forms of cholesterol, lowering your inflammation, improving your insulin sensitivity, lowering your body fat percentage, all these things are all going to feed towards that risk reduction when it comes to heart disease. But if you've got this far, thanks for listening or watching. As always, this was for informational purposes only. And if you are after medical advice, then go to your medical provider. Like I said, if you go to them asking about LP(a), there's a good chance they probably won't have a Scooby-Doo about it. So you will have to go privately. And then when you go privately, you may just get your blood test with just a random printout saying your level is this, with no context. So obviously, if you can get the right company to do the testing, go through them. You can obviously go through me if you really want to and you live in the UK. But I always advise to get it at least once in your lifetime. And hopefully you do not fall in the same category as me. But this is one of the only markers that actually has the inverse relationship, where the majority of the population have a low level as opposed to a high level, which is obviously a good thing, because we don't want to have a population with a very high baseline risk for cardiovascular disease, given it's the biggest killer and still reigning with no end in sight. But thanks for listening, and I will catch you in the next episode.